let's start with introductions. Okay, so I'm Chineze Ivenso. I'm consultant old age psychiatrist. I work in Newport in Aneurin Bevan University Health Board.
And I'm Elizabeth Bond, the pharmacist in mental health, working at Betsi Cadwaladr.
So, we did ask the other team to introduce themselves because it's nice to know who's round. So if you start from me.
I'm Sue. I'm a prescribing support pharmacist and I work partly in the intermediate care team as well.
Where's that too?
In Howard Bar headquarters.
Great. Nice to meet you.
I'm Kay, I'm a neurology nurse practitioner in the Heath, particularly interested in this one because my dad's really
Oh, there you go. I wondered what was urology doing here, but that's very good. Excellent. Yes.
I'm Suzanne. I work for Contact Health. I've got a split role as pharmacy and then working with local authorities, setting up care packages for patients in community.
Excellent.
I'm Santosh and I got a split role as well. Not recently, I was just
Oh, fantastic. Amazing.
I work with Contact. I do a mix of prescribing advisor and
Oh, fantastic.
I'm we're going to start with choice
Aneurin Bevan. I'm a practice pharmacist.
Lovely. Nice to meet you.
I'm prescribing support.
Excellent.
Yes, I'm Isabel. I'm a custody pharmacist in Sam Cardford. I'm also a pharmacist.
and so what kind of program of multiple interventions.
I'm Fiona. I'm a substance misuse nurse and prescriber. Working on CDA Bridgend.
Oh, Swansea Bay. Comtaff is Bridgend. Yes, that's right. Nice to meet you.
I'm Nimble. I'm one of the advanced nurse practitioners working adult mental health of patients in Contact.
Adult mental health. Interesting. Nice to meet you. So thanks for coming. Thanks for showing interest in this topic. I suppose Liz and I, maybe Liz, you can introduce how come we're involved in all of this.
So, I don't know if you're all aware of this guideline. Chineze and I were involved with co-producing this All Wales guideline on appropriate antipsychotic prescribing for people with dementia. So we just wanted to use this time to understand maybe how this is being implemented in your health board and share sort of tips on how we can make a difference for patients with dementia.
So, on the back of that, why is this important? Why are antipsychotics for patients with dementia, why is this an important topic? Why should we care?
Because of the side effects it carries.
The side effects, so what are they?
Cardiovascular risk
Cardiovascular risk?
can make dementia, if not used appropriately, can make dementia tremendous.
Oh, you've been doing some good reading. Yes, that's exactly it. So there's the risk of sudden death when this medication is used. There's also the risk of cardiac arrhythmias, and it can accelerate dementia. So that's what you've touched on. So I suppose, when can it be appropriately used? That's the question, because this is a protocol for appropriate prescription. So there is a time when it's useful. When is that?
When they're agitated,
When they're agitated. Hallucinating. That's interesting. I suppose if someone's agitated because they're thirsty, because they're in pain, would this be appropriate? So it's agitation, but it needs to be qualified.
yeah, explore.
Yes, so probably when there's a risk to self or others, that makes it urgent, and then that's why this is useful. Is there something we could do before we start using this medication, especially for patients with dementia?
Talk to the family.
Oh, talk to the family. That's a really good one. Yes, that's very good. Why would the family want to know?
If you're caring for them or seeing them or going to the care home or wherever the person is, residing, and to give you a picture of how things have been.
That's right. So there's a lot of reasons. That picture of how things have been. Because if I have a very vibrant personality and suddenly I get dementia and I'm still vibrant, that's not a change. But actually, if someone gets elated a bit more than what would be usual, then that's important to pick it up. But also, a lot of patients with dementia don't have capacity. They can't agree to medication that's as serious as this. So maybe the family will be the proxy to give permission to use such serious medication.
The public protection, they call
The power of attorney. Yes, that's right. And it has to be power of attorney for health and welfare, not finances. Finances won't cut it. Just saying. So that's useful. I suppose, what's your experience of working with patients with dementia who have been on antipsychotics? Some of you are pharmacists. Do you come across patients with dementia?
Every other patient I might be one of them.
Every other patient. So even if you're not the one who's prescribed the medication, is there some role when you come across these patients? Is there something you could do that would make that count? Your being with that patient would make a difference to that patient. What could you do when you come across patients on this kind of medication, knowing how serious the side effects are? Pardon? So counselling who?
Counselling the patients on how to take it, and if they've got issues with remembering, adherence, if you do a reminder, and write down what all their medication is.
So that would help, because this kind of medication, you don't want them to take it in the wrong way. And obviously, not taking it reliably makes the risk small. So,
Non-pharmacological interventions like CBT,
so that would be before the medication. So give people an idea about what needs to happen before the medication.
keeping people in familiar situations, familiar faces, basis, and try and understand what the current capability is, and then work from there rather than assuming their capacity or space.
That's right. So who knows how often this medication needs to be monitored? So if we start the medication, antipsychotics, for a patient with dementia, how often should we look again and see whether that medication is needed?
Imagine it being more often in an elderly person.
That's right.
From an adult perspective, we've got a guideline that we use it with somebody on antipsychotics. Because in an elderly person who's got other comorbidities, you'd be monitoring them far more closely.
Excellent. So NICE had something to say about that. So NICE said 6 weekly. So that's how often. So if you came across a patient on antipsychotics and you know they have dementia, one thing you could do is check whether they've been monitored recently. Yes. And if they haven't, what could you do?
arrange to have an appointment made.
With who?
The GP or whoever the prescriber is.
And that would be...
Well, most of the antipsychotics will be initiated either in hospital or in the community by a specialist team. Bearing in mind, sometimes antipsychotics are also prescribed for delirium in a general hospital, and a patient may be discharged on an antipsychotic inappropriately long term. So those patients do need to be reviewed, and they can be referred back to the specialist services just to review that medication. If people are started on antipsychotics by older people's mental health services, they should keep them under review and make sure that if they've tried to reduce and stop that medication, and the guidance goes through all the steps to take to make that happen. And there may be infrequent cases where if they try to stop the medication, the behaviour escalates again, and therefore they under distress as well. So sometimes a small dose of antipsychotic is continued long term for certain patients, but that needs to be clearly documented so that everyone is aware, including the GP. And I think communication is just so important, which is why in the guidance we've also advised some communication monitoring charts, not a prescription, but it's just indicating why the medication was started. Just highlighting what needs to be reviewed, because initially early on, patients could be really high risk of falls, sedation, dehydration, constipation, things like that, and they could lead to them being readmitted into A&E because of this. I've seen it happen. So it's really, really important that these patients are monitored closely initially, and then and reviewed as well. And so we provide a review section. There's two pieces of paper. You can share these around. Yeah, the document inside that, got all the documentation.
Just if you have a quick look at them.
So we're just in the process. The document's been circulated and published, and we had the webinar a month ago, I think, which I'm sure you've been privileged to watch as well.
One
And
of the
we're now
mental
in.
health pharmacists presented this to us in supervision a couple of weeks ago.
Oh, wow! What health board's that?
Contact.
Contact, okay.
We just want to see it happen in practice. Yeah.
So I wonder, what behaviours would it be that someone has dementia and they have this behaviour, and then you think, what behaviours are we talking about? What are the behaviours that challenge?
Disinhibited.
Disinhibited, yes, that would be one.
Maybe wandering.
Yes,
Last risk of getting out of the house, maybe falling,
hitting,
looking pinching.
that's right, throwing
Change
things.
of personality.
Yeah. So, if you imagine you start someone on this serious medication, you want to know whether that's making a difference. So you have to have a target. You need to know which behavior you're targeting, so that when there's a change to that behavior, you know that that has made a difference. So in the guidelines here, we have what we call the Cohen Mansfield Agitation Inventory. It's used mainly in research, but we thought it would be helpful because it kind of concentrates the mind on what behaviors we're talking about. So you go away with a free copy of the Mansfield, just in case you didn't have one. And I think a number of you are pharmacists, and so some of you know about the antibiotic stewardship. Maybe. And Liz had a very good idea about something to do in relation to that.
So we were thinking about how the antibiotic group have a stewardship group, and they have audit targets, and all the information from different health boards lead up to a central stewardship group. And we were talking to the very Mr. Andrew Evans about an idea of an antipsychotics in dementia stewardship group, maybe not just looking at antipsychotics, but psychotropic prescribing in general, so benzodiazepines, other sedatives that may be used to try and manage distress behaviours in people with dementia, so that we can get a feel for what's happening across Wales, and also share best practice, share where improvements are really happening, and that would kind of give us hopefully more motivation to improve practice and share good practice as well. So if you're interested in becoming involved with this stewardship group, we've got our contact details here.
More
We'd love to hear from you and hear your ideas on how we
Our
can
email
actually.
addresses at the bottom,
make
so if you'd like
changes
to
happen.
yes.
Because guidelines are all very well and good, but if they don't change practice, they're not worth the paper they're at now.
So we're looking for very keen champions to join the stewardship group, so that we can tackle this problem together. I think it might be useful maybe if we went round each person just for comments or any questions or something you want to bring to the group. I don't know if we should start from the back.
I would just say if you're interested in this, Liz and Nick did a really good learning at lunch video that's on the website, where they did a scenario between the GP and payments, like a case between interested parties. So if you want to more about it, watch their video because it's really good. The guidelines are really good for having something to refer back to, but actually hearing about how it works in practice. They did a really good video.
Where is it? Sorry,
It's on the AWTTC website under the Learning at Lunch section, so you just download them. It's a YouTube video. Okay. You can watch it.
It's gone viral. Just saying. Any questions or comments? Anything you'd like to share?
one of the pharmacists that we work with has just been doing medication for older person services, and I think she would be really interested to participate in something like this. So I might pass her details on.
Of course you are, of course.
We did a presentation last week about diagnosing the workforce in mental health because we can't recruit middle grade doctors into positions. So we're trying to attract pharmacist practitioners into mental health and pharmacists to supplement some of the roles. Because we're just chronically unable to meet targets and to see patients, and they don't always need to see doctors. So we're just saying about the things we need to be doing to kind of manage services better. So she did a presentation on reviewing. She did loads of data. She said, "I've seen so many patients and I've given so many medications, and I deprescribed, and these are better, kind of like outcomes." So I think they would be really interested to get in touch with us. They actually presented this to us.
That's so good. That's amazing.
We meet the nurses and pharmacists, meet to do supervision, and that's quite helpful. So we learn from each other.
Absolutely.
That's so good. I suppose just hearing you're an adult mental health practitioner, some patients with adult mental health problems have dementia. So younger patients do have dementia. So again, it's relevant to what you do.
So we do, obviously we have the ageing population. If somebody's within our service before the age of 65, we call them a graduate patient. We continue to see them. We do start to see patients who have cognitive impairment. There are difficulties in handing a patient over to sometimes older person services, especially when they've got CT and all of the things that need to be done, and often rationalising medication because some of our younger patients would have been on an antipsychotic or condition and never been reviewed, or they've gone from clinician to clinician and nobody's ever actually looked at why is somebody looking like they've got memory impairment. Well, they're on pregabalin, they're on this medication, they're on diazepam. We're not looking, we're not reviewing medication.
That's excellent. So we have 5 minutes to get round everyone. So comments, question, observation.
It's just interesting. Obviously, I'm working in substance misuse now, and I'm prescribing. It's just interesting to listen to everyone's.
Thank you. That's great.
So this was more information.
Lovely. Thank you.
I'm working on a project within the health at the moment, our medicine management team, where we review patients in their home with medication.
Oh, fantastic.
So it was just interesting to get some, making sure that monitoring, you realise that it's 6 weekly.
It's just as relevant for people in their own homes as it is.
And even though NICE has said 6 weekly, very few health boards actually meet that.
Yeah.
And then when you hear 6 weekly, when you start medication, as serious as this medication, maybe the next week would be sufficient to monitor, and a week later, then when the person is stable, go to 6 weekly. So it's a guide. Lovely.
Are you interested to look at how the anticholinergics with regards to that? I know we've all done a lot of work on that over the years, but I still see masses of patients on huge anticholinergic issues, amitriptyline, which is a 3, isn't it, on the scale. And so add anything into that, if you've got a patient who is over 65, 70, surely you're putting them at risk of heading down this.
That is such an interesting comment, because when you think about it, the stewardship group can't just focus on antipsychotics by itself, because it's within a milieu. So I'm sure you would join that. Yes.
I think I find that it's a bit when you see a patient where you think actually it's not necessarily appropriate, where you go with a lot of patients with the service at the moment, perhaps whilst they're going for 6 weekly, often they fall off, or when they're if they're not in like any acute issues, it's just where to go and how to get the patient perhaps reviewed again to discuss whether they've actually could look at prescribing.
Well, that's a very good question, isn't it? So, maybe your older adult mental health service, so referring back in, just asking the question of them, okay? And possibly sometimes if you do need to through the GP, but you could try and see if you could go direct.
Making sure they're aware of the diagnosis as well and that they're informed.
Yeah.
I mean, in general, I find lack of awareness everywhere regarding, especially because symptoms are overlapped with other mental health conditions.
That's right.
And I find including doctors, nurses, pharmacists, and general lack of awareness on how to deal with the symptoms and differences between differential diagnoses and different well. Sometimes we know the theory, but we don't know how to put it in practice and where to refer to. Like, for instance, I don't know where to find patients. Or for the next 6 weeks, we don't know that it's not it's not enough resources to use those kind of.
Yeah, that's interesting. So what you raise is the extrapyramidal side effects. So you do need to know what the EPSCs are so that when you see it, you know what it is. And then, like you said, to refer to the right people so that they can actually de-prescribe if it's needed. Thank you.
I was going to say, I think looking at it from another aspect as well, in contact we've got about 790 medication patterns for patients in the community. And when they're getting discharged on something like this, and the directions say take one when required for agitation or anxiety, one carer's perception of agitation could be different to the next carer going in, and is that person then getting unnecessary doses of that medication, and it's reviewing those as well.
That's useful.
I think, I think it's really important to have really clear instructions for any PRN medication. Like I say,
the instructions would be, because I've seen it myself, for anxiety or agitation, but your perception.
Okay, thank you very much. If you could move to your next session, please.
That's right. Yeah. But antipsychotics aren't normally used as a PRN, so if you see that, please question it. Yes.
Yeah, no, very interesting, good introduction. I need to delve into when I need it.
Yes, fingers crossed, we might not need it. Reassurance might work. And yes?
Yes, I work in the care homes and in intermediate care reading units, so it's useful to use this.
Lovely. Yeah, so hopefully some of you will join the stewardship group. Thank you.